Okay. Well, as I say, thank you very much indeed for inviting me. The partnership that we have at Bristol Health Partners covers Bristol, North Somerset, South Gloucester. It's a population of about 1.1 million. In many ways, it's relatively small and beautifully formed, and it makes life a lot easier compared to some of the very large ICSs in London or in the north. So we are served well by two universities, the three local authorities, the ICB, which covers all of that, the two acute trusts, the Mental Health Trust and Serona, who provide all of our community services. As well, we have NHS Blood and Transplant, which is a highly specialised unit out at Filton, which does a lot of the genetic modification work used for bone marrow transplant. And most recently, we've also included the two organisations that provide in hours and out of hours primary care services. So we really now span all of social care, public health, and all of care in the community and in the hospitals. We are also in negotiations with Avon and Somerset Police to see if they too would like to join the partnership, because a number of the hits that we work with directly involve the police. So I thought it might be helpful, after talking to Martin and Virginia, as to sort of give you a little potted history. We started in 2010, so we've just had our 13th annual conference. It was day before yesterday, and I'm pleased to say it went very well. So, when we started back in 2010, we had very limited local collaborations. There was no forum where the regional strategic health providers or social care were in any way meeting with either of the universities. We had a much smaller sort of local partnership between the two acute trusts and the medical school, which is where almost all of the clinical academics were working and providing clinical services. But other than that, there really was very little else. We had enormous enthusiasm from our researchers. We had one relatively small BRU, as it was in those days, a biomedical research unit, but that was absolutely it. But much more to the point, there was absolutely no mechanism nor route for local decision making regarding linking research or research and innovation with those who are making decisions, let alone delivering the health and care services. So our journey over the last 13 years has really, I think, been very successful. In 2020, we became one of only 8 formally designated AHCs in England. As I'm sure you're aware, it's a very rigorous process, despite the fact that there's absolutely no money on the table at all. But it is the kudos that it opens and gives you to play up there with the relatively big boys in the Golden Triangle and places like the Mayo and the Karolinska. Is a very useful thing to be able to do. And also it puts us on the international stage. Our priorities are mental health, health inequalities in children and young people, which unsurprisingly are exactly the same priorities that we have in our ICB as well. And that's not a coincidence, that is by design. Indeed, the recent ICB strategy, as published, the work of Bristol Health Partners was intimately involved and woven into it at pretty much every stage, going right from prevention through to primary, secondary and tertiary care. As Martin has already said, the way we actually deliver the work that we do falls under the category of health integration teams, or HITs. We have well over 20 now, and the important point is that they are from the ground up. We tried initially to almost commission HITs and said, oh, we would like one in the following areas, and it failed miserably. Essentially, what you really need is a group of interested and positive clinicians, patients, partners, and researchers and commissioners if this is going to work. And that model has served us very well from the outset when we started rolling it out. The only thing that has changed is that initially we were very focused around the very standard chronic health conditions, dementia, musculoskeletal, kidney disease, and stroke. But as the years have gone by, we have massively broadened it out. And very much now, our view is to focus on what I would call the cracks in the system, the difficult areas that everyone normally puts into the, oh, that's too difficult box, we'll come back to that, or where we know there are gaps in the system where everyone quite happily passes the buck around and goes, well, it's not really us that delivers that. Yes, it's terribly important, but it's not us. And as a result, what we have become and what the HITs have become is effectively a vehicle for having conversations and, for want of a better term, politically getting the parties to the table to agree how we're going to undertake service change, and most importantly, bring to bear the existing research evidence where we have it, or to generate the research evidence ourselves. And the more recently, the things we have particularly focused on are prevention. And, you know, the really big ones, drugs and alcohol, healthy weight. We are just about to approve one around tobacco cessation. Then we have things like active, healthy lives, you know, improving sexual health services, immunization and vaccine, and particularly for children, the life course around adversity and trauma, otherwise known as adverse childhood experiences. I mean, if you can get families and intervene early, you can massively move the dial. You can move children who come from excluded, deprived, and very difficult backgrounds and integrate them into mainstream education, remove them from constantly being arrested, and that's where the police come in and so on. And you can, if you work intensively with these families, make an enormous difference. And that's not surprising, an area for us that's a major priority. You know, we have a big inner city deprived population, a rural coastal community, and we have a coastal seaside town, Weston-super-Mare, which is one of the top 5 most deprived areas in the entire country. And as a result, all of these HITs now span all of those areas and start to really work at scale, trying to move towards prevention, optimizing clinical services. So that's really what we've focused on over the last 13 years, and particularly during the time of COVID, we have also introduced and really focused on inequalities, excluded communities, those most deprived, and to really focus on how can we bring them back, not just into the clinical service, but also into research as well. The key here is to build trust with those communities, because many of them have very, very little trust in the NHS or in research. Their view generally is they've given, they've participated, but no one's told them what's happened, and more to the point, from their point of view, nothing has changed. So if you look at where we are now, the Academic Health Science Centre has become the formal research and innovation steering group for our ICS. That happened almost 2 years ago now. And that only really occurred because we had those close relationships for 8 to 10 years before. We have joint leadership for the AHSC and the ICS. Almost all of the chief execs and senior partners for the ICS are also partners in our AHSC. Again, that close working, that close relationship over many years, and the trust that goes with it is what underpins success in this sense. We have joint posts now between the university and the ICB. We have more multiple programs and project level collaborations between our HITs and the ICS than probably we have HITs. And more, many of the big ICS work programs are effectively almost being handed over to the HIT and told, you know what you're doing, let's work with you to really integrate research and clinical delivery in a way that optimizes both. And lastly, we have provided and continue to provide oversight for all of our NIHR infrastructure under the NIHR umbrella at Bristol. So that's our ARC, our CRF, our BRC, our CRN, the trials unit, the 3 schools of primary care, public health and social care. They all come together and meet regularly and exchange best practice. And that again allows a very seamless integration and joint funding between the infrastructure for various programs that we all agree are important. So if I try and tell you what our strengths are, I suppose number one, obviously, it's the HIT model. We are still the first and in many ways, I think, the most advanced in that model. And many other places, not just you, are starting to talk to us about emulating that, not just in the UK, but elsewhere as well. We are centered around patient and public involvement from the ground up. And that's probably the biggest single thing we've done. We have the mantra now that no HIT can be formed without at least 2 patient and public partners being directors on the HIT. The Research and Innovation Steering Group has at least 3 partners sitting on it, and similarly the board has 3 partners sitting on it. We take them at the view that if we're doing anything that doesn't involve our patients and partners, then we aren't doing it right. We act on a commitment to equality, diversity, and inclusion. We have now got a huge work plan around that. We've been successful in the NHSE REN 1 and REN 2 bids, so we now have a very active research engagement network, and we're just waiting to hear on our round 3 bid. As I say, we've got very committed partners who are focused on adding value and improving health and care for our region by integrating health and care with research. So the Research and Innovation Steering Group that we've got for our ICS, it's worth noting it's the first formally to do that in the country, and many of the other AHSCs would love to be able to emulate the degree of integration we've got, and thus far many of them have not achieved that. So in terms of how could we done it better, this is a tiny little alleyway round the back of the Bristol Royal Infirmary, and I thought it was a nice sort of picture because it gives the impression that you might end up down in a blind alley. Well, actually you don't. If you walk round that corner, you come to a big, beautiful open green space. So there's a nice metaphor there for you. But I think if I look back, and I was one of the founders of our health partnership, so I've been there from the outset, is I think the 2 things I would really say from the ICS ICB point of view is we as the researchers really need to understand their system priorities from the outset. Timing is absolutely key. If you go in too early when they're just setting themselves up, particularly given the changes in the ICS over the last couple of years, too soon they'll go, oh, go away, come back later. On the other hand, if you leave it too late, then all of their work streams and all of their partnerships are already done. I think the other point I would make, and we certainly made this mistake at the beginning, is the potentially incorrect assumptions around a focus on and support for research. Just because individual members of what was then the CCG and some of the more senior clinicians in the trusts all said, oh yes, research is terribly important. We really must make sure we include that at all levels. When you get down to the next level, the managers in the trusts, the managers who make the decisions on the investments in specific services, to be quite frank, a lot of them went, talk to the hand, we're not interested in that at all. It's a nice little bolt on and add-on and we haven't got the time. So it was only really when we got that major buy-in from the top that it really started to make an effect. And again, if there's one of the very few things that have come out of COVID, it was the demonstration so explicitly to the ICB at all levels what research could do from them. The speed, the rapidity, the breadth and depth of what we did, the fact that so many of the senior academics in the university just basically stopped everything else and focused on what we were doing around COVID. I mean, I was one of the people that ran the regional COVID response, and it was a very effective time. And I think those relationships that we built up, they have been enormously helpful as we've now come through the pandemic and the other side. As soon as the ICS was really setting itself up, it amazed me. I had the chief executive of the ICS saying to me, David, we must make sure that research is involved at every stage. This wasn't me pushing against a door. It was him opening it and essentially pulling me through it. I think I would leave you with this slide, and I think I've sent these slides on to you, so I'm very happy for you to share them. But, to be absolutely honest, the way you get engagement with the ICS is to tell them what's in it for them. If you just go to them and essentially asking them for resource or commit their people's time to what you're doing, and they don't see the payback from their point of view, you're not going to get much of a response. Key relationships really, really matter. Your senior people in your health partnership, people like the chief medical officer, your director of strategy, your director of transformation for your ICS, they must be working closely together. They must see the value in what we do as well as us seeing the value in what they do. There's no doubt that AHSC designation certainly reinvigorated the interest across our whole system in the partnership. And as I've already said, COVID really showed the practical value of what we could do by integration and working together. Clear expectations from the outset are really important. If you leave things fluffy and unsaid and nebulous, then people, not surprisingly, will be disappointed and slightly hacked off. Similarly, you need to agree the scope. We are very clear. We do research and innovation. Things like education and workforce remain within the existing ICS programs. We don't largely get involved in that, although obviously they're very important. And lastly, and by no means least, having the backing of the national and regional NHSE teams really pays enormous dividends. It's well worthwhile having them. They can unlock many things at regional and national level that your own ICS or ICB will not be able to. So my last slide, in terms of widening the pool of people who are members and champions, both from our side and from the ICS's side, is very important. You can't just have the same few individuals saying it's great. You need to work your way down through the organizational levels to make sure that the middle level people understand the value of what we do and what we can offer. Efficient and collaborative ways of working, not surprisingly, are vitally important. I think now that the AHSNs have been redesignated as HIs, in this case HISW, we need to be working very closely with them as we do at the moment, and similarly as we do with ARC West and our other NIHR infrastructure. And lastly, and I can't overestimate this, you need to continue constantly to demonstrate to them explicitly the tangible examples of the impact of what we all generate. Because again, it comes back to the same thing. If they don't see it, what's in it for them, they won't really pursue this further. There is no point in having long HTA-funded trials that take 5 or 6 years, and by the time the answer has finally come through, the answer is almost certainly irrelevant or things have moved on by then. So it needs to be rapid, either the evidence synthesis or the review or the sorts of programs that you're doing and that our HITs are doing. We all, for all of them, expect them to deliver within a year, 18 months at the most. Anything more than that, and the people you're talking to won't be there because of this enormous churn and turnover in the clinical side. So thank you for your time. And happy to take any questions.
Thank you very much, David. Can you hear us?
Yes, I can.
Fantastic. Thank you. And I've certainly got lots of things I'd like to ask more about it, but I'm going to give people in the room a chance to answer some questions first, if I may, and hopefully you'll be able to hear, they'll be able to hear your answers. Anyone like to ask any questions, please?
Thank you. My question is about the rapid response from COVID, because we were able to get our studies, really important studies to do very quickly during COVID, but it feels like the system's sort of gone back to the pace that it was before, and mine was about implementation. So I absolutely recognise what you're saying, that we were doing really important research, but the systems have quite often moved on by the time we come to implement it. How have you addressed that in the West?
Well, you're absolutely right. Of course, people only love you when you're delivering something that's important to them. But as I said, it's about building those trusted relationships at middle and senior level of the clinical commissioning partners and the trust. They understood and saw the benefits. So it's not some ephemeral thing that came and went. You need to bang on and show them how the activity and what you generated can be replicated and continued in the post-pandemic world. And that, again, I think is largely about trust and also about partnership working. The more you have in terms of breadth and depth that spans the ask. So it's not just, the clinical research network, here are the 97 studies we're delivering, but how are you addressing their needs? How can you bring the research evidence or generate it rapidly to fulfill the needs of the commissioners and the trusts in terms of their clinical service? So, Bristol Health Partners is not really about generating the classic studies that the CRN delivers. It's much more about integration and changes and alteration in pathways more than anything else, I would say.
Any other questions from the audience?
Hello, David. It's Alan Sutton on the pensions and public representatives of the HRP, newly appointed. A lot of the stuff we hear sometimes is in silos, and I haven't seen any silos in what you've actually delivered and done there. How did you get around that? There are silos existing in research, and I'd just like to hear how you didn't end up with silos at the outcome.
I'm sorry, it's going to sound facile, but basically you need to work together from the get-go and make sure that there are no silos. And if people attempt to have silo working or mentality, it basically needs to be called out and addressed from the word go. We haven't really had silos in any aspect of our research across Bristol, North Somerset, South Gloucester, or in terms of our health partnerships. We work together in a very integrated way. But again, I'm afraid it's the same answer. That doesn't happen overnight. There's no recipe book for this. It's about working together for individuals for 5, 10, 15 years before you really get that change in mindset. Yes, you will always, on the clinical side, whether it's in the hospitals or primary care or in the ICS for that matter, you will get new people who come along who tend to default back to the silo working. But the fact that the ICSs have come in and their mantra is the system, everything is owned by the system, the control total is owned by the system, healthcare delivery is across the system, this really speaks to that in volumes. I guess it really depends on the stage of evolution of your ICS and the partners, and I can't obviously speak to that.
Thank you.
Hello, David. My name is Stephen Lightfoot. I'm the chair of the NHS Sussex Integrated Care Board and also the chair of this Health Research Partnership. So we're starting.
You're the key man then.
We're starting to work together. I'm interested, you talk about all the public sector partners. Have you had any commercial involvement from, at all, or is it entirely public sector?
It's entirely public sector, and that's by design, not by accident. We have huge commercial activity, both in the 2 universities and in the trusts. We have a joint commercial enterprise that spans both of the acute trusts with a turnover in excess of 6 million a year in terms of clinical trials, focused on the areas we're particularly expert in, vaccines, oncology, to name but 2. But in terms of the health partnership, it's very much around the ICB footprint and the ICB partners. I have taken the view, and I continue to be of the view, that the minute you start bringing in larger commercial organisations, you change that dynamic, you change the conversation. To be quite frank, things are difficult enough to corral people in terms of herding cats without having the commercial side muddying the water further.
Yeah, I think it's great.
Thank you.
I wanted to ask Dave, if I may, about you talked quite a bit about the importance of the interaction with the ICB and how you approach that. I want to ask a bit about the interaction with the ARC, in that you talked a little bit about that, but we've also had an ARC in this region much longer than we've had the concept of a research partnership. And I think we're still struggling a little bit to understand what the relationships between those two bits of the puzzle are. And I'd be interested to see how you approach that and what issues you encounter.
I'll do my best. So to answer the first bit, I'm sorry, I don't think I can say more than what I've said already. It's about long-term working, it's about trust, it's about partnership, it's about both parties seeing and understanding what they can get out of it. As I think I mentioned in my presentation, having joint funded posts and exchange posts where you have members of, say, the ICB who spend 6 to 12 months in one of the universities and vice versa, placements in other words, that works very well. Again, those people in turn can then act as ambassadors and create the bridge further. In terms of your other question about the ARC, again, I think we've been relatively fortunate in that we had our Clark, which then changed into its ARC. So again, we've had that as part of our NIHR infrastructure from the get-go, essentially. So we've got a very well-established relationship, particularly focusing around primary care and mental health, and now more recently children and end of life. So again, those are all mantras and very important for the work of the ICS and ICB. They're equally important for the ARC and for all of the partners. So again, it's not difficult to make sure that everything is joined up. It's more a case of, again, to be honest, corralling people and trying to keep them on message rather than everybody going off and trying to just do their own little, well, not little, but their own more focused projects. It's important about keeping an eye on the bigger picture. And that, again, is where our umbrella organisation led by the AHSC comes in, because we provide that oversight and make sure that things aren't being forgotten or falling through the cracks. Does that answer your question?
It does. It's a brilliant overall message. Thank you. That's very much the message we're trying to get our thinking around today. Any final questions for David? So if not, thank you very much. That's really been enormously insightful, David. Thank you for your time. Really, really appreciate it. We'll let you go and get on with the rest of our
well, enjoy the rest of your day, and thank you for inviting me. All the best.